Hey guys, welcome to Exam 2 Review. This is going to highlight some of the important different things that you guys will see on the exam. Again, this is going to be no surprise to you. These are going to be things that I've talked about in lecture. These are going to be things that I've talked about many times. They'll be in objectives. They'll be important points that I said to make note of. But again, let's kind of jump into this. And excuse me if you guys hear a dog. Again, I'm working at home. We obviously don't have electricity today. I'm kind of battling a cold, so just kind of bear with me, guys. So, a patient presents with a bacterial infection. It doesn't matter the clinical vignette that I give you. I could say that he's got strep, staph, he's got Yersinia pestis. It doesn't matter what he has. All it matters is that I say the word bacteria. It's a bacterial infection. So, you need to know that bacteria. The primary immune cell that's going to respond are going to be neutrophils. Neutrophils are going to be the primary white blood cell that responds to those. And we can recognize neutrophils on peripheral smear by the presence of 2 to 5 lobes. Again, I want you to know that bacteria, neutrophils, right? In that same sense, whenever a patient presents with a parasitic infection, right? Remember, parasites have to live off the immune host. We're going to think about eosinophils. Eosinophils are going to be primarily elevated within the peripheral smear. And eosinophils are going to have a pink appearance on the peripheral smear. Again, look back at your guys' lecture slides, be able to recognize these. Neutrophils have the appearance of 2 to 5 lobes. Eosinophils have a pink appearance. So just like Sabrina mentioned in class, let's say that there's a 26-year-old patient. They're walking on the beach and they notice a red, itchy lesion present at the lower extremity after they've been walking barefoot down in South America. Develop a cough later. They notice, they go to the physician. The physician does a CBC with peripheral smear and notices an elevation in the eosinophil count. Which of the following was the patient most likely in contact with? And that would be eosinophils. That would be a parasite, right? That would be a parasitic infection. Okay. Next, knowing the blood's different functions. For example, white blood cells serve an important immunological role within the blood. During an active infection, they provide defense. So provide defense against foreign antigens. This would be an example of protection. If for some reason I was to mention pH homeostasis within the body, that's regulating the body, right? It's regulating the pH. The normal pH within the body is going to be between 7.35 and 7.45. Transportation, again, blood is going to be important for transporting different gases, whether it be carbon dioxide or oxygen, to the heart, as well as different nutrients, okay? So these are important different functions of blood. Paying attention to protection. Protection being the primary one that we need to pay attention to. We've talked about things such as formed elements and blood plasma. We know that blood plasma is going to contain a lot of different proteins, right? So blood plasma is going to consist of a bunch of different proteins. Some of those could be fibrinogen, which is used for hemostasis, albumin, which is a transport protein, also responsible for oncotic pressure, antibodies. And we know the formed elements are what? Formed elements are going to be the red blood cells, white blood cells, platelets. Awesome. Do you guys remember the characteristics of the red blood cell in terms of its shape? Red blood cell shape, biconcave. What did I say was unique about it? Lacked a nucleus, right? You remember which stage it actually begins lacking a nucleus? It's important. Reticulocyte, right? So reticulocyte is an immature red blood cell that lacks a nucleus. There's one right before that. That's called a it's like a hematoblast, hematocytoblast, something along the lines of that. But essentially, the reticulocyte is the immature red blood cell where it actually lacks the nucleus. Um, cool. So we've kind of went over um, the different functions of blood: protection, regulation, transportation. We talked about blood plasma containing the different proteins, fibrinogen, albumin, as well as antibodies, and then the formed elements being the actual whole portion, whether it be the red blood cell, the white blood cell, and the platelet. We said the red blood cell had a unique shape. It was bioconcave, and we said that was important for, do you guys know? O2 exchange, oxygen exchange. It allows proper loading and unloading of oxygen. And it also lacked a nucleus. And we said the last um, red cell that was responsible or that had a nucleus was something called the hematocytoblast. But the reticulocyte was the immature red cell that lacked the nucleus. Okay. So building on from that, about um, let's talk about how red blood cell homeostasis. So let's say that a patient comes to you and they present with anemia, and anemia is low hematocrit or low blood count. So they could have a history of bleeding, have iron deficiency anemia, anything that's going to cause us to have low blood. How will your body increase the red blood cell production? You guys remember the hormone that's responsible for doing that? It's going to be erythropoietin, EPO. Erythropoietin signals the red bone marrow to increase RBC production. So once we have enough red blood cell production, it's then going to shut off the amount of red cell production. And it does this through a process called negative feedback. So EPO increases red blood cell production and reaches homeostasis via negative feedback. Okay. Just want you guys to kind of be aware of the whole mechanism of erythropoietin stimulating red blood cell production. Then once we have enough red blood cells, it then shuts it off via negative feedback. Cool. We talked about the way that hemoglobin breaks down. So hemoglobin is made up of heme and globin. You know that globin is just a protein, so it breaks down into amino acids. Awesome. We said that heme is going to break down into bilirubin. So, for example, if a patient with sickle cell disease presented to you and they had right upper quadrant pain, they were diagnosed with bilirubin gallstones, what would be the cause? And it would just be due to hemoglobin breakdown. So, I would say this as a general rule of thumb: any type of red blood cell breakdown equals increased bilirubin production. Okay. Cool. What else can we go over? We talked about the different hormones that were responsible for increasing the different formed elements. So for red blood cell production, we talked about EPO, erythropoietin. Do you guys remember what platelets, how those increase? This thrombopoietin. And what about white blood cells? Colony stimulating factor, absolutely. So white blood cells will increase by colony stimulating factor. So if a patient presented to you and they had bone marrow dysplasia, they had maybe they had a plastic anemia or something along the lines of that, where white blood cells are just not being produced. I'm sorry, not a plastic anemia, but myelofibrosis. Let's say they had myelofibrosis and white blood cells are just not being produced. We could increase the amount of white blood cell production by giving them a hormone or a drug that mimics colony stimulating factor. And there's actually some drugs out there that work to mimic colony stimulating factor, that transcription factor that increases the production of white blood cells. So be aware of those. Okay, so this will cover at least the first little bit. Let's talk about, let's say that you've got a 26-year-old male with a history of recurrent viral and fungal infections. What are we thinking about? What responds to viruses and funguses? This is what I want you to be able to pick out in the questions in the clinical vignette. I want you to think about T cells. Anybody know any conditions that primarily affects the T cells? HIV, AIDS, right? This is going to affect the CD4 helper cells. We'll cover that in a little bit more detail later on in the immunology section in this class. So T cells. What about if I told you that they recurrent bacterial infections? Neutrophils. Awesome. Not just neutrophils, could also be, I guess I should preface this with B cells as well. But for our purposes, I want you to know that recurrent viral and fungal infections is going to be a T cell immunodeficiency. That's primarily going to be due to the fact that the T cells are going to be the immune cell that's going to respond to these viruses and funguses, right? The CD8 cytotoxic T cells. The process of immigration. What's the other word for immigration? Diapedesis. This is going to be the process in which white blood cells respond to a foreign invader. Right. It's going to do this through a few different ways. One is going to be rolling. It's going to roll along the endothelium. Then it's going to stick to the endothelium. Then it's going to squeeze through the endothelial cells to the active infection, and it receives these chemical signals called interleukins. Interleukins will be these chemical mediators that kind of tell which cell one to come out, but it also directs them to the site of the foreign invader. Okay, so rolling, sticking, and squeezing through the endothelium, that's going to be important. Then we covered also primary hemostasis, and we covered the different portions of primary hemostasis, right? Primary hemostasis is also known as platelet plug formation and formation of the fibrin meshwork, right? We said we were going to form a weak platelet plug. We said that the initial um, uh, first step, I guess, the initial step in primary hemostasis was vascular spasm. Vascular spasm. So there's an insult, there's an injury to the blood vessel that is going to cause the endothelial cells, the smooth muscle, to contract. This is going to be called vascular spasm. After we have vascular spasm, we're then going to have the release of chemical mediators, which is then going to trigger adhesion. Adhesion will then occur, and eventually we'll have the formation of the fibrin meshwork. So the initial step is primary hemostasis. What's the vascular spasm? The final product, formation of fibrin meshwork. Okay. Awesome, awesome, awesome. Fibrin meshwork, also known as fibrin threads. I don't want you guys to get confused. Okay. This is synonymous with each other. Okay, this is primarily going to cover the first portion of our lecture. This is going to cover the first. This is going to cover blood. So after that, we'll get into the cardiovascular lecture. We will get into the. We'll get into. Let's start at the beginning of the lecture, and we'll kind of talk about the layers of the heart themselves. So. Let's say that let's say there's a fella up the holler and he gets into a knife fight, right? He is just he's wild one night at Coyote Den and he gets stabbed. Okay, he gets stabbed. Bless his heart. I hate that for him. but which layer would the knife first pierce? And this comes back to your knowledge about how the pericardium itself is arranged. So the very first layer is the fibrous pericardium. That knife's going to go through the fibrous pericardium. This is this tough outer layer of the pericardium. We know the visceral pericardium is going to cover the heart itself. In between visceral and the fibrous is going to be the pericardial cavity, which will have a small amount of fluid. Allow them to move back and forth on each other, right? So the fibrous pericardium is this tough outer layer. Let's talk about blood flow. How does blood flow, right? How does blood flow through the vena cava system to the pulmonary trunk? In order for blood to flow from the vena cava, so let's say the superior vena cava and the inferior vena cava are going to pass through the right atrium, okay? They're going to have to pass through the right atrium. From the right atrium, they will go through something called the tricuspid valve. From there, they'll go through the tricuspid valve into something called the right ventricle. And from the right ventricle, they'll move in through the pulmonary valve into the pulmonary trunk, also known as the pulmonary artery. From the pulmonary artery, they'll then go there for the lung. Now, I want you guys to realize we talked about the difference between systemic and pulmonary circulation, and Cameron wanted me to cover this pretty well, and I think it's important. I think this is very good because this is something that we've talked about numerous different times, but knowing the path of blood flow is important, but also knowing what type of oxygen do we have in this right-sided circulation. Is this oxygenated or deoxygenated? We have to ask yourself, where is the blood going? Okay, the blood is going from this right side to the lungs. Okay, so it has to be deoxygenated blood. Can't spell today. Deoxygenated blood. So deoxygenated blood going to the lungs to load up with oxygen. Cool. So now once we're in the lungs, the pulmonary artery takes this to the lungs, right? We are now in the lungs, right? So the pulmonary vein now contains oxygenated blood. It's going to take it to the left atrium. From the left atrium, we're going to go to the left ventricle, but before we do that, we have to go through the mitral, also known as the bicuspid valve, and then we're going to go into the left ventricle. Cool. From the left ventricle, we're now wanting to get into systemic circulation. Because we have this oxygenated blood, we want to pump it to the rest of the system, to the rest of the body. We're going to do this by pumping it to the aorta, but first we must go through the aortic valve into the aorta. So again, I just want you guys to realize that you have a pulmonary and a systemic circuit. The pulmonary circuit is going to be right-sided in nature. You're going to have this deoxygenated blood, which is going to be pumped to the lungs, right, in order to get oxygenation. So from the right side, we have the vena cava system. We have this superior vena cava and this inferior vena cava, which is going to empty this deoxygenated blood to the right atrium. Awesome. That's great. We are now in the right atrium. We're then going to pass into the right ventricle. But before we do that, we're going to have to pass something called the tricuspid valve, right? So from there, the right ventricle is going to pump blood through the pulmonary valve into the pulmonary artery. From the pulmonary artery, the blood is going to be taken to the lungs. Awesome. Once we're in the lungs, this now oxygenated blood is going to come back to the heart so it can be pumped to the rest of the circulation through the pulmonary vein. The pulmonary vein has oxygenated blood, okay? So the pulmonary vein is going to take this oxygenated blood from the left atrium, send it through the mitral valve into the left ventricle, through the aortic valve into the aorta. Now again, I wrote a case study that was kind of showing you the pathophysiology of heart failure. I said that the left ventricle stopped working, and I asked you guys, where would the blood back up? Or just give you guys the question. If we couldn't pump as much blood forward, right, the ejection fraction was reduced, what would we do? Where would the blood go? And we said that the blood would leak backward. it would leak backward, eventually into the lungs. So it got cold from the left ventricle into the mitral valve, right? Into the left atrium, and eventually into the pulmonary vein, and eventually into the lungs. So again, anytime that there is a break in the pump, the blood backs up. Okay. So, for example, let's say that the mitral valve, let's say that we had a problem with closing of the mitral valve, right? The mitral valve didn't close as well. Then again, blood would back up into the left atrium, and again, it would go into the pulmonary vein, and again, into the lungs. So, I just want you to realize how, if something breaks within this pump system, how blood accumulates. I think it's very important and very good. Like maybe on the exam, if you're having trouble thinking about where would the blood go, write it out. Write it out. Write the route of blood flow. Know your chart that you guys have written for me on quizzes, and just know how blood moves forward, and if something happens, where it would go. I digress. Okay. So, what chambers of the heart will contain oxygen poor blood? Again, we would know that would be the right atrium and the right ventricle, right? That's no surprise. So, what portion of the lungs would have oxygen rich blood? Right? That'd be the left atrium and the left ventricle, right? Um, okay. Again, we talked about if there's a break in the pump, where does blood go? So, if I have an ejection fraction, let's say of 25%, that probably doesn't mean a whole lot to you. But if I told you the normal was 55%, you could tell me that's significantly reduced. Okay. The heart is only working roughly 25% of what it should be. Um, so if blood can't go forward into this aorta, it has to back up um, posteriorly, right? Or I guess posterior is probably not the right word, but it has to back up behind it, behind the pump. So again, it would back up into the left atrium, and again to the pulmonary vein, and again to the lungs. Awesome. So I think that this is essentially all you guys really need to know in terms of blood flow. If you guys can tell me this in terms of systemic and pulmonary circulation, if you can tell me this for blood flow, I think you guys are going to be fine for the exam. So now we talked about cardiac conduction, and we'll talk about that in a little bit more detail. We talked about the different phases. We talked about the resting membrane potential was when the cell was electrically negative, so cells are in a negative state. We then said that depolarization occurs whenever we have opening of the fast gated sodium channels. Then initially, once the sodium channels will begin to slow down and shut off, we'll have something called the plateau. And the plateau is going to be characterized by potassium efflux and calcium influx, right? These are slow gated calcium channels. And it's these calcium channels which come in inside the myocardial cells and are going to be able to bind and cause contraction. So calcium causes contraction, right? Now, repolarization is reestablishment of the resting membrane potential. So we're getting more negative, okay? Depolarization was becoming more positive, and repolarization is becoming more negative. Go back to your slide, look at that picture, and understand kind of what this is. So repolarization is going to be primarily due to potassium efflux, right? And then we're going to have repolarization back down to the resting membrane potential. So we've got these different phases. I think depolarization, knowing that depolarization is becoming more positive and knowing it's due to the fast-gated sodium channels, okay? This is going to allow the electrical signal to get through the SA node, to get down to the AV node, again to the bundle of His, and to the left and right bundles, eventually to the Purkinje's. Having this cardiac action potential is going to allow conduction to occur. So depolarization occurs due to the fast-gated sodium channels. Then we have the plateau, and the plateau is going to be primarily due to a calcium influx and a potassium efflux. Again, they're kind of offsetting each other, causing a plateau effect. Because of this calcium influx, you can have contraction. Contraction occurs within the plateau phase, and I want you guys to know that. And I want you to know about the fast-gated sodium channels, okay? These are important points. And repolarization occurs due to potassium efflux. So now we talked about how the electrical signal passed within the cardiac conduction. We went from the SA node to the AV node to the bundle of His to the left and right bundle to the Purkinje system. We said the SA node was primarily responsible for what? Atrial contraction. Or we'll just say, yeah, right atrial contraction. What's this representing? When we talk about the SA node activity, in terms of the EKG, which waveform is responsible for right atrial contraction and SA node activity? Do you guys know? That's going to be the P wave. And I'd like for y'all to know that. So as it begins to travel through the SA node, it then goes through the AV node, and this is going to be represented by the PR interval. I don't think you guys need to know this for my purposes. If you are going to go on and train in medical school or go on to another professional school such as PA school or nurse practitioner school, then it may be important for you guys to be aware of that. But again, for our purposes, I'd like for you to know SA node for right now. So now we're going to get into the QRS interval. This is going to be ventricular contraction. This will also be Purkinje's. And then get down here to the T wave. And again, the T wave is going to be responsible for repolarization of the ventricles. So for our purposes, knowing these, we talked about these in class. I told you to write them down. And I think that, again, they're going to continue to be important. Knowing the SA node, knowing that it's responsible for right atrial contraction, knowing it's represented by the P wave on ECG reading. Knowing the AV node, not really essentially important for us in terms of tracings. But in terms of the QRS is going to be where ventricular contraction occurs. And we know that the Purkinje system is going to be present within the ventricles, causing that increased speed of conduction and allowing the ventricles to properly contract. And once the ventricles have contracted, repolarization is then going to occur. This is going to be represented by the T wave. Cool. And again, I think that you guys, I would hope that you guys know the pacemaker of the heart by now, right? SA node equals pacemaker of the heart, right? It sets our heart rate. So now let's talk about hemodynamics in terms of cardiac output. So we said that cardiac output is going to be the amount of blood from the heart. Cardiac output is equal to what? Do you guys know the two components? Heart rate times what? Volume. So in order, if I, let's say that I was asking which of the following would increase the cardiac output. Increase heart rate. Increase stroke volume. Now, what components dictate the stroke volume? Do you guys remember this? We talked about three. Preload. Afterload. Do you remember the other one? Contractility. Awesome. So contractility is how well is heart contracting. Preload is amount of venous return, how much blood is brought back to the heart. This is also synonymous with end diastolic volume. We said that during diastole, the heart was relaxing. So this means that it's filling with blood, right? And I said that the heart can't pump what it doesn't have. Think about this. The heart cannot pump what it does not have. Therefore, if there is low amount of venous return or a low amount of end diastolic volume, the stroke volume has to be low because there's not enough blood in the heart to pump it out. Okay? Afterload is what's after the heart. And I like to think of this as blood pressure. So how much pressure is the heart um, pumping against, right? What is how much pressure is the heart having to generate in order to pump blood out into the rest of the systemic circulation? And then contractility is how well is the heart contracting. So what would increase stroke volume? Okay, we talked about these three factors. So what about preload? A high or low preload? Increased preload, right? Decreased afterload, right? We want a low afterload. We want low blood pressure, not essentially too low, but we want a normal or a lower amount of afterload in order for the heart to effectively pump. And then contractility, increased contractility. These are all going to be things that increase the stroke volume. So if you increase the stroke volume, you're going to do what to the cardiac output? Or you should, if compensation is not present. Right. You should increase the cardiac output. Absolutely. So any of these factors, if you increase the preload, there's going to be an increase in the stroke volume, which is going to do what to the cardiac output? It's going to increase it. If you decrease the afterload, you're going to increase the stroke volume, which is going to do what to the cardiac output? It's going to increase it. If you increase the contractility, you're going to increase the stroke volume, which is going to do what to the cardiac output? It's going to increase it. So hope that you guys see how I'm kind of coming to these conclusions. For our purposes, I would like for you to know this formula. Cardiac output is equal to the heart rate times the stroke volume. I would like for you to know the different things that make up the stroke volume, knowing the preload, knowing the afterload, knowing the contractility, and even more so, how could we increase this stroke volume? These factors, by increasing the preload, we increase the venous return, which allows for more blood to be ejected from the heart. That's why you have an increase in the stroke volume. If you decrease the afterload, decreases the pressure the heart has to pump against. You increase the contractility, then you increase the amount of blood the heart can eject. Okay? Knowing your valve anatomy, knowing that the mitral valve is between the left atrium and the left ventricle, knowing your tricuspid valve is between the right atrium and right ventricle, that'll be important for us. Knowing now your sympathetic nervous system and parasympathetic nervous system. This makes up something called the autonomic nervous system. So the sympathetic nervous system stimulates the heart to increase the heart rate for increasing cardiac output. Parasympathetic nervous system decreases the heart rate. Okay. Okay, naming the layers of the heart. Cool. So what is the heart layer that we talked about earlier? It's the first layer, it's protective epicardium. Said it was made up of the fibrous and the visceral pericardium, right? You guys know what's the next one is? Myocardium, right? It's the muscular layer, it's the middle, and then the inside is also known as the endocardium. This actually lines the valves. There's something called endocarditis where you get bacterial vegetations on the valves, right? So you know that they're on the valves, so it has to be the endocardium. So these are the three layers. This is the outermost, middle, and then deep. So this is going to cover cardiac. Now let's get into lungs. So go over a few basic things. So the vocal cords are located where? Larynx. You've got true and false vocal cords. You guys remember about androgens increasing the thickness of the folds, which is responsible for deepening of the voice, occurs at puberty. Okay. We talked about the larynx. We also talked about, let's say this goes back to the case study. You've got a 25-year-old male gunshot victim who is found down with hypoxia. Hypoxia means low oxygen. Gunshot wound found at T5. Why is this guy hypoxic? He's got a gunshot wound at T5. What branch is at T5? Tracheal bifurcation. So the trachea bifurcates into what lobes? Primary and secondary lobes. And why would this guy be hypoxic? What's the trachea responsible for doing? Well, what part of the is this part of the upper or lower airway system? It's part of the lower airway system, right? So it's going to conduct oxygen from the upper respiratory system down to the lower respiratory system, right? Into the primary and secondary lobes of the lung. And to the primary lobes, the right and left main stem bronchi, primary lobes, and then eventually the primary lobes, we said would send it to the secondary lobes, which would send it to the tertiary lobes, which would then eventually go to the respiratory bronchioles, which would branch off into the alveolar ducts, which would then go to the alveoli. So, awesome. Knowing that the trachea is present at T5, that's just a little tidbit. Knowing that the trachea is going to be responsible for conduction of oxygen down to the lungs. Knowing the branching of the lobes, primary goes into secondary, secondary goes into tertiary, tertiary goes into terminal bronchioles, terminal goes into respiratory, respiratory goes to the alveolar ducts go to the alveoli. Cool. We talked about the muscle, we talked about inspiration. Okay. Inspiration, lung volumes increase, causes a decrease in pressure. We said that diaphragm contracts, external intercostals contract, right? We said that during expiration, lung volumes decrease, which increases the pressure. We said the diaphragm relaxes, external intercostals relax. Remember, this is a passive process. We talked about the pressure gradient between the atmosphere and the alveoli. The pressure is greater in the atmosphere than the alveoli, which forces air into the lungs. We talked about the different lung volumes. I would like for you to go back and review those. The definition questions, right? So, for example, inspiratory reserve volume is the amount of air that enters the lungs during forced maximal inspiration. Go back and review inspiratory reserve volume, expiratory reserve volume, vital capacity, and tidal volume. Knowing the difference between type 1 and type 2 alveoli. Type 2 alveoli secrete surfactant. Surfactant is responsible for decreasing the surface tension and therefore preventing airway collapse. Knowing the order of the pharynx, the different pharyngeal structures. Nasopharynx is first. This is this is the nasal cavity and the pharynx. Oropharynx, this is the oral cavity and pharynx. And laryngopharynx, larynx, and pharynx. So knowing that it is New Orleans, nasopharynx, oropharynx, laryngopharynx, New Orleans. With these type 1 or type 2 alveolar cells, we talked about in class neonatal respiratory distress syndrome, NRDS. So NRDS, neonatal respiratory distress syndrome. We talked about premature newborns that had insufficient secretion of surfactant. Due to low surfactant, these patients develop lung collapse. Cool. Symptoms of laryngitis. I want you to think about this. What is presence within the larynx? This is actually something I'm just getting over. So the vocal cords. So think about something with a voice, raspy voice, hoarse, something like that. Maybe even a loss of voice. That's what you would think about. Those are the symptoms. You don't even have to know essentially what laryngitis is, right? You just know that the larynx, you know what's there. You know, itis is inflammation of whatever's in the larynx. So I think about the vocal cords. So I know that it has to be something with voice, and you would be able to pick out the right answer choice. This is how you take tests, guys. Let's see, what else can I touch on? Deoxygenate. Okay, let's go back up here. Deoxygenated blood is carried to the lungs via the what? We just talked about it earlier. Pulmonary artery. Awesome. Oxygenated blood is carried to the heart via the pulmonary vein. Good. Again, we talked about this feller that's up the holler. He went out to Coyote Den. Instead of getting stabbed in the heart, he got stabbed in the lung. So, stabbed. So, dude stabbed in the lung. What structure is it going to penetrate first? Or let's say he got shot. Dude got shot. Dude shot. Not that it makes a difference, right? He's in trouble. Dude shot in the lung, right? We're talking about some type of pleura. I hope you're thinking of pleura of some sort. So what types of pleura do you have? There's parietal. It's going to align the thoracic cage. What's a thoracic cage? Think about the rib cage, things like that, things within the thorax. And then we've also got the visceral. This is directly on the lung itself. Okay. So if a dude is shot, stabbed, whatever it may be, and I'm asking you, what is it come in contact with first? Some type of pleura, right? I would have to specify and say that it was primarily the rib cage. That would be parietal pleura. Or I'd have to further differentiate the pleura that's directly on the lung, something like that. Either way, I want you to think visceral pleura. We talked about, again, with the heart, we talked about the sympathetic and parasympathetic nervous system, but again, it's also implicated within the lungs. And I hope you guys remember this. Sympathetic nervous system is going to cause what? Bronchodilation, widening of the bronchi, increases airflow, helps breathe better. This is after Ricky Joe up the hall, or he's out deer hunting, gets chased by a bear for whatever reason. He's running, he's scared to death. His sympathetic nervous system kicked in, right? His heart rate's going crazy, stimulating his heart rate, trying to keep him alive, increasing the cardiac output. And then he's also having bronchodilation, right? There's something called the beta 2 receptor, which is present in the lungs. You don't have to know that right now, but if you're going on into medical school or nursing or something, you're going to talk about the beta 2 receptor. It's present on the lungs, and epinephrine, which is secreted again, if you remember from the endocrine lecture, it's secreted from the adrenal medulla, right? And then it's going to go to the lungs and cause a binding of the beta 2 receptor, and it's then going to cause bronchodilation. Okay, there's a medication that works like this, right? It's called albuterol. Medication in asthmatic that increases bronchodilation. So if someone's having an asthma attack, we give them albuterol. Albuterol works to bronchodilate, right? It works kind of similar to the sympathetic nervous system. So the pathophysiology of asthma is very similar to the parasympathetic nervous system. This causes bronchoconstriction. Okay. Tightening of the airway reduces airflow. Shortens the breath. So I hope you guys can see these implications with this. This stuff is really cool. We talked about the nasal cavity, and we talked about the different things that were present within the nasal cavity. The septum separates the right and left nares. What did I say about the septum? I told you guys one weird thing. I thought you guys might remember this. What causes a perforated nasal septum? It's not on the exam, but it's kind of, I don't know. Right? Cocaine abuse. Perforated nasal septum. We talked about the nasal concha, increasing surface area. The olfactory receptors for smell. Nasolacrimal duct. Okay, so different things here. Go back, review the nasal cavity anatomy. Conducting zone. Responsible for what? Conducting air into the lower respiratory tract, aka the respiratory zone. Respiratory zone equals side of gas exchange. Okay. I think this is going to get most of it, guys. Um, I think that you guys are going to be fine. I really do. I think that you're prepared. I think that you guys have worked hard. I'm proud of you guys. I think that, um, yeah, I'm really proud of you guys. If you have any questions, again, reach out to me. You're never going to aggravate me. I'm here for you. I'm here for your success. We're all doing this together, trying to muddle through life. So just let me know if you have any questions. Email me, reach out to me. Thank you, guys.